Hi there. This is Empowering Everyone, a trauma-informed care education presentation. My name is Kelsey Kindler, and I'm a BSN to DNP psychiatric mental health nurse practitioner student at Texas Tech University Health Sciences Center. I wanted to start with a quote about trauma by Laurel K. Hamilton. There are wounds that never show on the body that are deeper and far more painful than anything that bleeds. I hope this puts some things into perspective, that medicine is not just the body, but also the mind, and how the mind then affects the body. Some objectives I have for this presentation are: I'd like you to gain a better understanding of what exactly trauma is, recognize how trauma affects physical health, gain insight to how to implement a trauma-informed environment into your clinic, understand how to avoid the two pitfalls, and most importantly, gain an overall sense of comfort in implementing this holistic approach to healthcare. So, what is trauma? The exact definition is argued over, as there seems to be no universal definition of trauma. However, the Substance Abuse and Mental Health Services Administration has defined it as follows: individual trauma results from an event, series of events, or a set of circumstances that is experienced by an individual as physically or emotionally harmful or life-threatening, and that has lasting adverse effects on the individual's functioning and mental, physical, social, emotional, or spiritual well-being. Some examples of trauma include, but are not limited to, physical, sexual, and emotional abuse, childhood neglect, living with a family member with mental health or substance use disorders, sudden unexplained separation from a loved one, poverty, discrimination, and historical trauma, and violence in a community, war, or terrorism. Now, these examples mostly stem from the ACEs study, which we will get to in a moment. SAMHSA also defines it as the 3 E's: events, experience, and effects. In other words, when someone is exposed to a traumatic or stressful event, how they experience it greatly influences the lasting effects of carrying the weight of that trauma. This definition alone highlights that a traumatic experience is highly individualized. How one person experiences an event could be drastically different than how someone else does. So, as I mentioned earlier, in 1998, the CDC and Kaiser Permanente conducted a study to examine how adverse childhood events influence adult health. They used an ACE questionnaire, Adverse Childhood Experiences or Events, which focused on abuse, neglect, and household dysfunction primarily, and assessed 17,000 participants. They found 2/3 of participants had experienced one or more ACEs, with 87% having 2 or more, 22% having 3 or more, and 13% having 4 or more ACEs. The ACE study found a direct link between childhood trauma and chronic illness, incarceration, and employment struggles. The higher the ACE number, the higher the negative outcomes. Then in 2012, the Philadelphia Urban ACE study was conducted. In the original ACEs study, the primary demographic was white middle-class men. So in this study, they took a racially diverse sample of men and women in Philadelphia between the ages of 35 and 65, all of which had completed high school. What they found was that 83% of participants had 1 or more ACEs, and 37% had 4 or more. The purpose of the study was to see if living in an urban city exposed people to more traumatic experiences. As you may already see, trauma affects more people than the average person may realize. But what is the impact of that trauma? Compared to those with no ACEs, those that have experienced 4 or more ACEs have an increased risk for COPD, sexually transmitted infections, smoking, suicide attempts, alcoholism, and injection of street drugs. The total estimated lifetime cost associated with just 1 year of child maltreatment, $124 billion. There's also research to show that trauma has an effect on obesity, diabetes, depression, heart disease, cancer, stroke, and broken bones. It also has an effect on non-medical factors such as graduation rates, academic achievements, and time taken off of work. Now, when we examine the effect of trauma on the brain directly, studies have found that traumatic experiences in adulthood invoke flight, fight, or freeze responses. Now, these responses aren't inherently bad, as it is how the brain is wired for survival. However, when responses are turned on for too long, they become toxic due to the constant flood of adrenaline and cortisol, which has lasting effects on the body's functions. Trauma experienced in childhood or adolescence may stunt the prefrontal cortex development as well. Traumatic experiences can cause people to see the world as a place of danger, which could result in depression, anxiety, fear, and anger. This could lead to people finding solace and comfort in unhealthy coping mechanisms such as alcohol, drugs, food, and other high-risk behaviors, which again ultimately leads to dangerous health issues. So what is trauma-informed care? Simply put, it is shifting the mindset from what's wrong with you to what happened to you. Far too often, there is a stigma associated with mental health and mental illness. People who experience traumatic events in their lives often feel shamed for seeking help. Statements such as, "This is my fault. If I would have just done what he said, he wouldn't have hit me." Or, "My mom loves drugs more than she loves me, so something must be wrong with me," can cause people to assume trauma is something they caused, when in reality, it is something that has happened to them. As healthcare providers, it is our job to make it clear that their traumatic experience is no fault of their own. Instead, it is something that happened to them. And we are here to help them receive the help they need to work through that experience. In 2014, SAMHSA came out with a guidebook on trauma-informed care. The majority of these concepts in the presentation are from that guidebook. One of the concepts is the 4 R's of trauma-informed care. Those 4 R's are realization, recognize, respond, and resist re-traumatization. Now we need to realize the widespread impact of trauma and understanding potential paths for recovery, recognize the signs and symptoms of trauma in individual clients, families, and staff. We respond by integrating knowledge into policies, procedures, and practices. And this presentation is part of that response. And finally, we need to actively resist re-traumatization. I will go more into this later in the presentation, but some ways that this can be done is avoid creating an environment that inadvertently reminds patients of their traumatic experiences, causing them to experience emotional and biological stress. Utilizing the 4 R's is done at both the organizational and clinical level. At the organizational level, this is done by leading and communicating about the transformation process, engaging patients in organizational planning, training clinical as well as non-clinical staff, creating a safe environment, preventing secondary traumatic stress in staff, as well as hiring a trauma-informed environment. At the clinical level, this is done by involving patients in the treatment process, screening for trauma, training staff in trauma-specific treatment approaches, and engaging in referral sources and partnering organizations. Now, SAMHSA and the CDC came out with the 6 leading principles of trauma-informed care: safety, trustworthiness and transparency, peer support, collaboration and mutuality, empowerment, voice, and choice, and lastly, cultural, historical, and gender issues. Now, the first principle is safety. Many trauma-affected patients have a persistent danger orientation. As we talked about earlier, trauma affects the brain in a multitude of ways, one of which is the fight, flight, or freeze response. Because patients can get stuck in these responses, they view the world as a dangerous place. It's our job to ensure both patients and staff feel physically and psychologically safe. This happens when the physical setting is safe and the interpersonal interactions between staff and patients promote a sense of safety. Now, what does this look like in this clinic? Keeping common areas, bathrooms, entrances, and exits well lit, as well as keeping the noise levels low in the waiting room. Using welcoming language on all signage, And when you are in an exam room with a patient, ensure that they have a clear access to the door and can easily exit if desired. That way they don't feel trapped, especially while you're screening for a trauma history. The second principle is trustworthiness and transparency. Again, these patients potentially are in situations where the only person they can trust is themselves. The goal of building and maintaining trust with clients and family members, as well as among staff, is paramount. This is done through making contact with the patients and agreements honestly. And if there are any inconsistencies with the visit or education, it's important to validate that confusion for them. They might experience and acknowledge that problem. The third principle is peer support. Peer support and mutual self-help are key vehicles for establishing safety and hope, building trust, enhancing collaboration, and utilizing their stories and lived experiences to promote recovery and healing. Peer support is kind of an abstract concept, but it is a flexible approach to building mutual healing relationships among equals based on core values and principles. Ensure that this patient-provider relationship is not one of a power dynamic, but rather voluntary, non-judgmental, respectful, reciprocal, and empathetic. The fourth principle is collaboration and mutuality. This is achieved by creating a level playing field between staff and clients and is very beneficial to the treatment process. Utilizing skills such as power sharing and mutual decision-making helps to facilitate collaboration and build trust. Also, allowing grievance, venting, and validating their feelings will also be beneficial. The fifth principle is empowerment, voice, and choice. You might have noticed the pattern already, but these principles build on each other and work together to create a trauma-informed environment. This, in my opinion, is one of the most important principles. Patients coming from abuse, neglect, or household dysfunction oftentimes have no voice or choice. When they are in the clinic exercising autonomy over their body, it's a great opportunity to allow them to have the voice and choice in getting help. Clients are supported in shared decision-making and goal setting to determine the plan of action they need to heal and move forward. Services are voluntary and patients are supported in cultivating self-advocacy skills. Staff are there to facilitate recovery rather than control it. And the final principle is cultural, historical, and gender issues. This concept is not new, nor is it reserved exclusively for trauma patients. However, it is an important concept to highlight when interacting with trauma patients. As healthcare providers, we need to actively move past stereotypes and biases and offer access to gender-responsive services. There is power in tradition, so use that to your advantage when working with a patient strong in their cultural beliefs. Incorporate policies, protocols, and processes that are responsive to the racial, ethnic, and cultural needs of individuals served in the clinic. And lastly, recognize and address historical trauma. As we learned from the ACEs and Philadelphia study, what happens in childhood has lasting effects, so don't forget about historical trauma. I know that was a lot to take in. We're almost done with this presentation, I promise. Well, learning about trauma, how it affects the body and health, and how to facilitate a trauma-informed environment are all critical concepts. That potentially comes with a couple pitfalls. Two that I want you to focus on are avoiding re-traumatization and doing your best to combat vicarious trauma. So as I mentioned earlier, resisting re-traumatization is one of the 4 R's. A patient comes into the clinic and is screened for childhood trauma. It is imperative that in the line of questioning, your demeanor, the physical setting, etc., doesn't re-traumatize the patient. It's important to anticipate and be sensitive to the needs of clients who have experienced trauma. This is done by tending to the client's experiences. And ignoring clients' behaviors and emotional reactions to having their traumatic memories triggered is more likely to increase these responses than decrease them. Some signs of distress are anxiety, fear, powerlessness, helplessness, worry, and anger. Some physical signs would be nausea, lightheadedness, an increase in blood pressure, heart rate, or respiratory rate, or maybe a headache. The signs I see most often when talking about trauma histories is crying, becoming uncooperative, argumentative, unresponsive, or restless. There may also be some cognitive signs such as a memory impairment or being a poor historian. Now, these signs are obviously not exclusive to being re-traumatized. It could also be a response to thinking about that trauma rather than being traumatized while thinking about it. It's important to develop an individual coping plan in anticipation of potential triggers that an individual is likely to experience in treatment based on their history. Now, recognize that effort to control behavior such as blocking the exit or physical restraint can cause traumatic stress reactions, particularly for trauma survivors whom being trapped was part of their trauma experience. Respond with consistency and listen for the specific trigger that seems to be driving the client's reactions. Also, ensure that you or your coworkers do not shame the patient's trauma or their behavior through teasing or joking about the situation. That can further stigmatize the trauma and therefore talking about it. Some normalizing responses you could use to help destigmatize their trauma are, I believe you. I believe what happened was wrong. There is no excuse for that. I believed what happened was not your fault. I believe events like this often cause harm. Many people experience whatever symptoms they're experiencing as you report. I believe people can get better. I am willing to help. I believe you are brave for sharing your experience. The next pitfall to avoid is vicarious trauma. You may also have heard it called secondary trauma or compassion fatigue. Now, the definitions for each term are not identical, but for the purposes of this presentation, they are synonymous. It's no secret that being in healthcare means you have a desire to help people, which is a quality to be celebrated. However, it is one that will require boundaries. It's admirable to want to walk into the fire with some of these patients. However, if you aren't taking the proper steps to take care of yourself first, it's a quick route to burnout. We've all heard the analogy on airplanes that you have to put the oxygen on yourself before you can put it on anyone else. Working with patients who have experienced trauma is no different. Secondary trauma is a common reaction to working with clients who have experienced trauma and mirrors the symptoms of PTSD, which are listed below. Vicarious trauma can result in staff burnout and high turnover rates for organizations as well. How can you avoid it? The short answer is self-care. However, that looks different to everyone. For some, it is as simple as a bubble bath and smooth jazz. For others, it's seeing a therapist once a week to unpack the work week. I can't give you a recipe for how to avoid it, but I can tell you that both you and your organization are responsible for it. Organizational strategies include sufficient time off and providing a safe physical space. Organizations should keep caseloads small to the best of their ability, provide routine reflective supervision provided in a safe space without fear of administrative repercussions, and psychoeducation about secondary trauma. Now, because this is a new concept to this facility, these strategies may come with time, so be patient. Some personal strategies you can include but are not limited to are support through good nutrition, exercise, and stress reduction. Again, this is not one size fits all. Your approach to avoiding vicarious trauma needs to be introspective and individualized. The important thing is you need to check in with yourself often and listen to what you are needing. Now, I know that was a lot to take in. I appreciate you sticking with me. The main takeaways I want you to leave this presentation with is 1, trauma affects nearly everyone at some point and can have a lasting effect on health. Number 2, through the 6 guiding principles of TIC, you can properly and compassionately help your patients in a holistic way. And lastly, self-care isn't selfish. Do what you need to do to make sure you are not only showing up for your patients, but also yourself and your loved ones. I've included my contact info in case anyone has any questions after this presentation, as well as some additional resources that I found interesting and helpful. Thank you so much for joining me on this new journey. And here are some references. Thank you.